Hello, this is again the educational channel for Professor Triple N or Nick PA from Brooklyn, New York. I'll present you with pulmonary board review sessions, part 1, 2, 3, and 4. Let's start from the end, which is part 4. Today is Wednesday, April 20th, 2022, about 6 p.m. in the afternoon. Let's start with slide number 2. Slide number 2 begins with the agents which prevents the progression of IPF or idiopathic pulmonary fibrosis. These are two medications. The first one is so-called pirfenidone, and another name for pirfenidone is esbriet. This is 200 milligram capsules. They spell ESBRIET. The mechanism of action of this medication is to regulate the production of growth factors and pro-collagen 1 and 2. The other medication which is important here is it's called nintedanib or OFEV. OFEV. It comes as a capsule of 150 milligrams. You take it usually twice a day. The mechanism of action is that multi-targeting the both tyrokinase tyrosine kinase inhibitors, the original one and non-original ones, and by that it blocks the fibrogenic growth factor and inhibits the fibroblasts. Let's go to the next topic, which is sarcoidosis. Sarcoidosis is, by definition, etiology is more common in African American women. It is an idiopathic inflammatory disorder, predominantly on the lungs, but can affect mostly of the body. It presents with the following. If they ask you what is the most likely diagnosis, you need to look for a young African American woman with shortness of breath on exertion and occasional fine rails of lung exam, but without wheezing and asthma. Erythema nodosum and lymphadenopathy, either from examination or especially on a chest X-ray, will hand you the diagnosis question. Sarcoidosis also presents with parotid gland enlargement, facial palsy, heart block or restrictive cardiomyopathy, CNS involvement, and neuritis or uveitis. Although the liver and kidneys granulomas are very common in autopsy, they are rarely symptomatic. Let's go to the next slide number 3. Slide number 3 we have on figure 6/17 sarcoidosis with bilateral hilar adenopathy. And if that there is a clinical tip here which we have to remember. The answer is sarcoidosis when on a chest X-ray or CT, it shows a hilar adenopathy in generally healthy African American woman. Diagnostic test. The chest X-ray is the best initial test. Hilar adenopathy is presented in more than 95% of the patient with sarcoidosis. Parenchymal involvement is also present with combination with lymphadenopathy. Lymph node biopsy is the most accurate test, and the granulomas are usually non-caseating. Also, there is elevation of ACE in 60%. Also, there is hypercalciuria in 20%, hyperkalemia in 5%. Granulomas in sarcoidosis, they make vitamin D. The PFTs shows restrictive lung disease, which means decreased FEV1, FVC, and TOC, with TOC is usually normal. TOC is decreased, but what I mean is the ratio FEV1 and FVC is usually normal. On a bronchoalveolar lavage, we see elevated levels of helper cells. Let's go to the next slide. The treatment is usually with prednisone, which is a clear drug of choice. Only few patients fail to respond, and also we have to know that asymptomatic hilar adenopathy does not need to be treated. Let's go to the next topic. This is thromboembolic disease. Thromboembolic disease, by definition, this is a P, or pulmonary embolism, or DVT, deep venous thrombosis. And essentially, they treat it as a spectrum of the same disease. Pulmonary emboli derive from the DVT of the large vessels of the legs in 70% and pelvic veins in 30%. Etiology, DVT usually arises from stasis due to immobility, surgery, trauma, joint replacement, or thrombophilias such as factor V, Leiden maturation, and antiphospholipid syndrome. Malignancy of any kind leads to DVT. What kind of clinical presentation it has, or if they ask what is the most likely diagnosis. We need to look for a sudden onset of shortness of breath with clear lungs on examination and normal chest X-ray. Other findings are tachypnea, tachycardia, cough, hemoptysis. Number 1. Number 2, unilateral leg pain from DVT. Number 3, pleuritic chest pain from lung infarction. Number 4, fever, can arise from any cause of clot or hematoma. Extremely severe emboli will produce hypotension. And there is clinical tip, but let's go to the next slide, number 5. The treatment, here the clinical tip is that mostly questions about PE is concerning the diagnostic testing and the treatment. So let's talk about diagnostic tests. There is no single uncomplicated diagnostic test for PE. Chest X-ray, EKG, and ABG are the best initial test. Angiography is the most accurate test, but can be fatal in 0.5%. After doing ABG, chest X-ray, and EKG, the best next step is most often CT angiogram. What is the clinical tip? There is a clinical tip for to remember, which states that in case of PE, the main issue is to know what is the most common finding and what is the most common abnormality when there is an abnormality. So on chest X-ray, it's usually normal on PE. The most common abnormality is atelectasis. We can see wedge-shaped infarction, pleural-based lesion like Hampton hump, and Westermarck sign, which is oligemia of one lobe, which are much less common than simple atelectasis. EKG usually shows a sinus tachycardia. The most common abnormality is non-specific ST /T wave changes. Only 5% will show right axis deviation, RV hypertrophy, or right bundle branch block. There is a clinical tip here which states that the most common wrong answer is to choose H1Q3T3 as the most common abnormality to be found on EKG. ABG usually shows hypoxia and respiratory alkalosis because of the high pH and low PCO2, with normal chest X-ray is extremely suggestive for pulmonary embolism. There is a clinical vignette here which describes a 65-year-old woman which had a recently hip replacement, comes to the emergency department with acute onset of shortness of breath and tachycardia. Chest CT shows normal, but there is hypoxia on ABG and an increased A/A gradient, and EKG shows sinus tachycardia. The question here is, what is the most appropriate next step of management? And the answers are few. Enoxaparin, A, B, thrombolytics. Let's go to the next slide. C, IVC filter. D, spiral CT scan and embolectomy. E, VQ scan or ventilation perfusion scan. F, lower extremity Doppler. G, D-dimer. The right answer here is A. When in the history or initial labs are suggested for PE, It is far more important to start therapy such as low molecular weight heparin or enoxaparin or with so-called NOAC. We'll talk about them later. And this is better than waiting for the results of confirmatory tests such as spiral CT or VQ scan. Spiral CT scan, or also called CT angiogram. The spiral CT has become the standard of care in terms of diagnostic testing to confirm the presence of P after X-ray, EKG, and ABG when they're done. The specificity is excellent, over 95%, and sensitivity is between 95 and 98. VQ scan is first only in pregnancy. So VQ scan or ventilation perfusion scan, this is a high probability scans, have no clots, false positive in 15%. Low probability scans for patients which have clots, they're false negative in 15%. A complete normal scan essentially excludes a clot. And here on figure 6/18, we'll see a VQ scan, which is still very useful in evaluating a PE, a positive test in the area which is ventilated but with decreased perfusion. So we can see A, ventilation, normal ventilation, and B, perfusion, decreased one. Abnormal areas of decreased perfusion with the arrows, the two arrows. On a chest X-ray, must be normal for a VQ scan to have any degree of, let's go to the next slide, accuracy. Do a spiral CT if the chest X-ray is abnormal. This is a clinical tip we have to remember. We are on slide 7. D-dimers. This test is very sensitive, better than 97% negative predictive value, but the specificity is poor. As this is so because since any cause of clot or increased bleeding can elevate the D-dimer level. A negative test excludes a clot, but a positive test does not mean anything. And there is a clinical tip here, which states that D-dimer is an answer when the pre-test probability for P is low and you need a simple non-invasive test to exclude thromboembolic disease. Lower extremity Doppler study or LE Doppler. If the LE Doppler is positive, no further testing is needed. Only 80% of PEs originate in the legs, so will be missed in 30% of the cases. You do not need to do a spiral CT or VQ scan to confirm a PE if there is a clot in the legs, because they will not change the therapy. The patient will still need heparin for 6 and then 6 months of Coumadin or warfarin. If the spiral CT is negative, VQ scan or LE Doppler negative, we need to withhold the therapy with heparin. LV Dopplers are a good test if VQ scan or spiral CT does not give a clear diagnosis. Let's discuss angiography. Angiography is the most accurate test with near 100% specificity and false negative less than 1%. Unfortunately, there is a 0.5% mortality, which is high if you consider 10,000 of tests a year. It will need to be done to exclude PE in all cases. When testing for PE, angiography is rarely done. Let's go to the next slide, slide number 8. Slide number 8 starts with a clinical tip, which states that what to do if there is no clear answer. However, the side effects of angiography, which is allergy, renal toxicity, death, are very clear question. Treatment for the PANP board exams, you'll be asked a clear question about management of APL syndrome. And it will be not asking you to choose between two acceptable forms of therapy. Which is LMW, which is low molecular weight heparin, or enoxaparin, which needs to be followed by NOAC, NOAC, or Coumadin or warfarin, which is accepted therapy. Other key facts about the therapy for APL syndrome is that NOx causes less intracranial bleeding than warfarin. NOx, number 2, this is number 1. Number 2, NOx do not need INR monitoring and do not need enoxaparin first. Number 3, NOx treat DVT in PE with efficacy at least as well as enoxaparin or warfarin. Number 4, the Gigatran can be reversed with idaruxizumab. Sorry for my accent. And number 6 is fundaxparimix is safe to use with patients which had HIT or heparin-induced thrombocytopenia. Fundaxparin nux is easy to monitor than argatroban. So these medications, rivaroxaban, all the bans, apixaban, doxaban, and dabigatran are so-called NOACs, which are oral agents which do not require INR monitoring and can be used for the treatment of PE. They reach the therapeutic effect in several hours, instead several days like Coumadin or warfarin. Warfarin requires initial therapy with low molecular weight heparin. So basically, NOACs are novel anticoagulants. So we have here TSOAC, or target-specific oral anticoagulants, NOACs, which is novel oral anticoagulants, or DOAC, which are direct oral anticoagulants. So here is the dilemma: NOACs, vice versa, DOACs, vice versa, TSOACs. Let me spell it for you. NOAC, vice versa, DOAC, vice versa, TSOAC. There is for medication of this class, which is rivaroxaban or Xarelto, which comes usually in 50 milligrams twice a day, apixaban or Eliquis, which comes with dose of usually 15 milligrams twice a day, edoxaban, which is Saviasa, which comes with 60 milligrams dose once a day, SAVYSA, and the last one is dabigatran, which is Prodaxa. The other name is Prodaxa. It comes with a dose of 150 milligrams twice a day. So when we have when the IVC filter is the right answer, when number one we have a contraindication of use of anticoagulants such as melena, CNS bleeding. Number two, recent emboli while on patient is on NOAC, or fully therapeutic warfarin as a INR of 2 to 3. If we have a right ventricular dysfunction, which has a enlarged right ventricle on echo, in this case, disease is so severe that IVC filter is placed because of the next embolus, which even small could potentially be fatal. So the question here is when the thrombolytics are the right answer. Let's go to slide number 9. So we continue here. Slide number 9, when the thrombolytics are the right answer. When we have number 1, hemodynamically unstable patient, for example, hypotension and tachycardia. Hypotension when the blood pressure is less than, systolic blood pressure is less than 90. And if we have acute RV dysfunction, here there is a clinical tip which states that there is no specific time limit in which to use the thrombolytics as there is in stroke or MI. And on figure 6/19, we'll see CT, we'll see IVC filter on a chest CT. And when the direct acting thrombin inhibitors as a argatroban is the answer. When we have a HIT or heparin-induced thrombocytopenia, In this case, fondaparinux is the inhibitor, which is alternative of heparin. Also, fondaparinux can be used if we have a case of HIT. When the aspirin is the answer, and the aspirin is never the right answer. Let's go to the next slide, number 10. We see here on figure 6/20 a Virchow triad, which is predispositions for venous thromboembolism. See number 1, stasis of the blood flow like immobility, CHF, recent surgery, endothelial injury from trauma, surgery, recent fracture. And number 3, hypercoagulability, like for example, factor 5 Leiden mutation, and any malignancy which can lead to DVT. Let's talk about pulmonary hypertension. The definition of pulmonary hypertension is when the systolic blood pressure is over 25 and the diastolic blood pressure is over 8. Any chronic lung disease leads to back pressure into the pulmonary artery, obstructing the flow out of the right side of the heart. Let's talk about the etiology. Primary pulmonary hypertension is by definition idiopathic. Any form of chronic lung disease such as COPD or fibrosis elevates the pulmonary artery pressure. Hypoxemia causes vasoconstriction on the pulmonary circulation as a normal reflex in the lungs to shut the blood flow away from the area of the lungs. It could be considered or consider that we have a poor oxygenation. This is why hypoxia leads to pulmonary hypertension, and pulmonary hypertension results in more hypoxia. Well, how is the clinical presentation? Usually dyspnea and fatigue. Let's go to the next slide. Slide number 11. Also presents with syncope, chest pain, wide split of S2 from pulmonary hypertension with loud P2 or tricuspid or pulmonary valve insufficiency. We need to remember that it's impossible to know the pulmonary hypertension is causing the dysfunction without testing. Let's talk about diagnostic tests. We can do chest CT or CT. The best initial test shows dilation of the proximal pulmonary arteries with narrowing or pruning of the distal vessels. The right heart or Swan-Ganz catheter is the most accurate test and the most precise method of measuring the pressure by vascular reactivity. EKG shows a right axis deviation, right atrial and ventricular hypertrophy. Echocardiography shows a RA and IV hypertrophy. Doppler estimate pulmonary artery or PA pressure. Also, we can do VQ scanning, which identifies the chronic PE as a cause of pulmonary hypertension. CBC shows polycythemia from the chronic hypoxia. How we do the treatment? Number 1, we correct the identifying cause when 1 is clear. Number 2, idiopathic disease is treated if there is vascular reactivity with number 1, prostacyclin analogs, or which cause a PA vasodilation. Number 2, and the names are mentioned there. Number 2, endothelium antagonist, and we have 2 names here. Number 3, phosphodiesterase inhibitors, and we can see them, sildenafil and tizanafil. And number 4, CGMP stimulators, and we'll see this difficult to pronounce name, Riociguat. And here we have to remember that there is all better than calcium channel blockers, hydralazine, or nitroglycerin. So all these medications are better than the 3-1, which we just mentioned. Let's go to the next slide, number 12. And also we can give oxygen, which can slow the progression, particularly with COPD. There is a clinical tip here which states that only a lung transplant is curative for idiopathic pulmonary hypertension. Let's discuss obstructive sleep apnea. Obstructive sleep apnea is that usually in case of obesity is the most commonly identified cause of obstructive sleep apnea. Patients present with daytime somnolence and history of loud snoring. Other symptoms include number 1, headaches, number 2, impaired memory and judgment, number 3, depression, number 4, hypertension, number 6, erectile dysfunction, number 7, bull neck. And clinical tip here is with increased bicarbonate sleep apnea is obesity / hypoventilation syndrome. Here we have to remember that the most accurate test is polysomnography or sleep study, which shows multiple episodes of apnea. Arrhythmias and erythrocytosis are common. The treatment, how we do it, number 1, weight loss and avoidance of alcohol. Number 2, continuous positive airway pressure or CPAP. Number 3, surgical widening of the airway or uvuopalato-pharyngeoplasty. And if this fail, let's go to the next slide, number 13. Number 2, we need to avoid use of sedatives. Number 5, oral appliances to keep the tongue out of the way. And this is the last topic which we need to discuss in part 4 of pulmonary notes. This is acute respiratory distress syndrome. By definition, and we're on slide 13, by definition, ARDS or acute respiratory distress syndrome is respiratory failure from overwhelming lung injury or systemic disease leading to severe hypoxia with chest X-ray suggestive for congestive failure but normal cardiac hemodynamic measurements. ARDS decrease of surfactant and makes the lung cells leaky so that alveoli are filled up with fluid. Etiology: ARDS is idiopathic. Large number of illnesses or injuries are associated with alveolar epithelial cells or capillary endothelial cell damage. Examples for this are number 1, sepsis or aspiration, number 2, lungs, number 3, contusion trauma, number 4, near drowning, and number 5, buzz and pancreatitis. What is the diagnostic tests? The chest X-ray shows bilateral infiltrations which are quickly become confluent or white out. Air bronchography are common. And here we have that if PO2 slash FiO2 is less than 300, we have ARDS, case of ARDS. If it is less than 200, moderately severe. If it is less than 100, it's severe case. Let's go to the next slide. Next slide, you can see on figure 6/21. You see air bronchograms which are a sign of dense consolidation of the lungs airspace. This is a case of pneumococcal pneumonia that left only the airspace in the large bronchi open, or air bronchograms. So ARDS is defined if we have a PO2 slash FiO2 ratio below 300. So the FiO2 is expressed in the decimal, so room air with 21% oxygen would be 0.21. If the PO2 is 103 in the room air, which is 21% oxygen or 0.21, then the ratio of PO2 over FiO2 is 500, 105 over 0.21. If the PO2 as measured on ABG is 70, while breathing 50% oxygen, the ratio is 70 over 0.5 or 140. ARDS is associated with normal findings on the right heart catheterization. The wedge pressure is normal, but it is necessary to measure. The treatment, low tidal volume mechanical ventilation is the best support while waiting to see if the lungs will recover. We usually use 6 milliliter per kilo of tidal volume. Steroids are not clearly beneficial in most cases. They may help in late stage disease in which pulmonary fibrosis develops. Basically, we have to remember here that no treatment is proven to reverse the ARDS. Do not forget to treat the underlying cause. Now let's go to the last slide, 15. PEEP or positive end expiratory pressure is used when the patient is undergoing mechanical ventilation to try to decrease the FiO2. Levels of FiO2 above 50% is toxic for the lungs. Maintaining a plateau pressure of less than 30 centimeters of water, this is measured on the ventilator. And this is the end of the part 4 of the pulmonary notes. If you have any questions or suggestions, please feel free to email me on my email, which is very simple, NICK, like Mary, D like dog, number 1 @gmail.com, or nickmd1 @gmail.com. Thank you so much.